Welcome to the Academy of Ultrasound's echocardiography, Echo232. My name is John Sheldon. I'm a registered sonographer, and I'll be teaching the course today. The first thing that we're going to talk about today is Echo232 week 1 deals with Chapter 9 in the Feigenbaum manual. If you'll make sure that you open your manual and take notes along with us, you'll be watching my screen, so you should be able to see, kind of follow along with me. Tonight we're going to talk about the pericardium and pericardial diseases. What you need to understand is the pericardium consists of two layers. You have the visceral, and you also have the parietal. There's about 5 to 10 milliliters of normal fluid within pericardial space. The pericardial space encases all 4 chambers of the heart and extends 1 to 2 centimeters up the great vessels. So when you look at a typical normal echo, you should see a small amount of fluid surrounding the pericardium, or inside the pericardium, between the pericardium and the actual wall of the heart itself, in the endocardium. It restrains the 4 cardiac chambers within a relatively confined volume and space within the thorax. Alterations in the volume of one chamber must by necessity be reflected in a change in volume in the opposite direction of another. So if you have an enlarged left ventricle, something is going to have to also have a change in volume. One chamber has a change in volume, something else is going to have a change in volume to accommodate that, because the pericardium basically restrains the heart within a certain size. Pericardial diseases can present as several different clinical scenarios. When we have a pericardial disease, the way that an echocardiographer knows that is by looking for a pericardial effusion, which is an increase in the fluid, and it says it can accumulate in any infectious or inflammatory process involving the pericardium. Most of those processes involve both layers of the pericardium. When you go over and look at Table 9-1, they show things that can actually affect the pericardium. You have things like idiopathic, acute idiopathic pericarditis, chronic idiopathic effusion. Idiopathic means that we don't know what causes it. It has some cause that we're not aware of. You have an infection, an infectious version, which could be viral, bacterial, tuberculosis, pneumonia, fungus. You have an inflammatory version, which is associated with connective tissue disease, such as rheumatoid arthritis, systemic lupus. You have a post-myocardial infarction format or process, which is after a transmural infarct or an MI, heart attack. It could be partial or complete with free wall rupture, could be delayed, and that's called Dressler syndrome. It's associated, or could be associated, with systemic diseases such as uremia, hypothyroidism, pregnancy, cirrhosis, and of course malignancy with cancers. We see a lot of this hyperthyroidism in the hospitals. The place I'm working at right now, we see consistent patients daily coming in with hyperthyroidism, and one of the things we need to be made aware of, make sure we cover, is to look at the pericardium real well and look for effusion, make sure there's no pericardial disease. Okay, so acute pericarditis of any etiology may result in an accumulation of variable amount of fluid. It's important to evaluate the left ventricular function to exclude myocarditis, where it actually affects the heart walls and the heart itself. A significant pericardial fluid reduces the total volume that the 4 cardiac chambers can contain, resulting in hemodynamic deterioration. There's something that we'll refer to later and discuss called tamponade. You have a hemodynamic deterioration because the more fluid that's enclosed in that in that chamber or in that sac, the less the heart can function as it should, the less space it has to function. So hemodynamic compromise is related to interpericardial pressure, the pressure on the chambers themselves, related to the volume of pericardial fluid, and the compliance or distensibility of the pericardium, how stiff it is. Slowly developing effusions are less compromising than a smaller but rapidly developing effusion. Inflammatory processes result in pain, and fluid accumulation chronically can result in fibrous strands and stiffening of the pericardium. So when you see a pericardial effusion, and we'll talk about that again as class goes on and show you some examples, you're going to also want to look to see if it's an echo-free space, if it's black, if it's very, very black and clear of any objects, or does it have fibrous stranding, which basically looks like white fibers running throughout that fluid. You have thickening of the pericardium, eventually can lead to pericardial constriction. Other types of pericardial pathology would be things such as pericardial cysts, congenital absence of the pericardium, which sometimes is an incidental finding in an asymptomatic patient. So for echocardiographic evaluation of the pericardium, how do we do that? How are we going to evaluate the pericardium with echo? Well, what we're basically going to do is it's going to be evaluated with M mode, 2D, and 3D, if you have it. Normally, there's a very small amount of fluid in the pericardial space, as I said. Very small echo-free space in posterior atrioventricular groove on figure 9.1. This area right over here that you're following me on the screen, this area right here is that little bit of pericardial fluid that you should have. This big round guy right here is the descending aorta, and that's what's going to allow us to determine if it's a pericardial effusion or if it's a pleural effusion. You want to keep that in mind also, and we'll come back to that. Since I've got a note here to make sure that you're aware of figure 9-2, let's scroll down to figure 9-2 and cover it also. 9-2 is an M-mode echo recorded in patients with pericardial effusions. So, in a normal M-mode that you've seen before, you do not have a lot of this fluid. You do not have a lot of this stuff that's actually out here between the wall of the heart and the pericardial sac. That is what a pericardial fluid or what pericardial effusion looks like. This little thing right up here is a pericardial effusion. That's what you're looking for, and that's what we're going to try to measure to see that we're going to put calipers on it and actually measure it. So let's go down to figure 9.3. This is a peristernal long axis echo recorded in a patient with a small effusion, and you can see the arrow there. It points to exactly where that small effusion is. This little area right here points to where that little tiny effusion is. Here is a little tiny effusion on the anterior side of the heart outside the right ventricle. Okay, figure 9-4. These are small, moderate to large. Number A is a small. Number B is a moderate to large. See the difference? You've got a much, much, much larger volume of fluid in a moderate to large pericardial effusion in this second one down here. Not as much fluid up top, a lot of fluid down here underneath the LV. This top one, the number A, would be a small effusion. It's actually there, but it's not nearly as elaborate and possibly you consider it to be a problem as the one down on number B. Let's move on to the next figure. 9-5 is a peristernal long axis recorded in a patient with a large effusion. This one measures 3 centimeters in its greatest dimension. In the real-time image, there is evidence of a swinging heart, which means basically the heart's been, there's so much fluid, the heart is actually swinging around inside that fluid pocket. So you see a large effusion. This is 3 centimeters. Apologize, my page is jumping on me here. Okay, you'll see figure 9-7. This is a parasternal short axis view in a patient with a large effusion. This one's more than 3 centimeters. You see the effusion area that's all down here up underneath the actual. This is a short axis of the LV. When you go to a 4-chamber of the same picture, you see the pericardial effusion out here on both the LV side and out here on the RA side. So it actually is circumventing the entire heart. This is a subcostal echo revealing a moderate to large effusion in a patient that's actually got, from the subcostal view, this is actually a circumventional or circumventing the entire heart also. This one is below the LV, this one is above the RA, RV. Okay, so that's quite a few pictures of actually what pericardial effusions look like. How do we detect a pericardial effusion? Well, we use all our echocardiography techniques, mainly the 2D. M mode, pericardial effusion, as I showed you, is going to be an echo-free space. The size is directly related or proportional to the amount of fluid. There's no accurate M mode techniques for quantifying volume, because M mode is just a straight line through one specific plane. There's no way of actually getting a volume. No accurate M mode technique for volume. Remember that. Isolated anterior free space is not specific for pericardial effusion. What I'm referring to is that if you've got an isolated space in the anterior portion of the heart, when you're looking at, for example, a parasternal long, this is a parasternal long view of the heart. When you're actually looking and there's an isolated space up here, that can actually be what we refer to as a fat pad. It's a accumulation of fat because of a patient's body size, their eating habits, those kind of things. It is not a pericardial effusion. The doctor would have to make the final call. You as an echocardiographer are just going to take the best pictures you can possibly take and let them make the decision. So 2D echo is used to screen for and to quantify pericardial effusions. Visual quantification is usually minimal, small, moderate, or large, and free or loculated. Loculated meaning that it's in one particular focal area, that it's not comprising the entire section of the heart. It should be characterized as to the presence or absence of hemodynamic compromise. Again, we'll refer to tamponade later. It appears maximal in the posterior atrioventricular groove. Again, the maximal posterior atrioventricular groove is this section down here. This is the atrioventricular groove. Additional views, you want the short axis, parasternal, apical, subcostal views, all the standard views. The circumferential extent of an effusion can be readily determined from those different views. A small effusion is as much as 1 centimeter of posterior echo-free space with or without fluid accumulation elsewhere. 1 centimeter and it's small. 1 to 2 centimeters are considered moderate, and anything more than 2 centimeters is considered large. Definitions may vary from lab to lab, but as far as right now, standards are 1 centimeter small, less than 2 centimeters moderate, over 2 centimeters large. In large effusions, the heart may swing within the pericardial space. Figure 9-10. Let's see if we can show you what that actually looks like. When it swings within the pericardial space, you know you've got a pretty substantial effusion. Okay, here's the 9-10. It's a 4-chamber apical view. See the large, huge amount of fluid that you've got, and the heart is actually just kind of bouncing around inside the sac. This is all pericardial fluid. This is all pericardial fluid, and the heart literally, with each beat, kind of bounces or swings around inside that sac. Effusions can be localized or loculated, again, very segmented. And it's not uncommon after cardiac surgery or cardiac trauma. So if somebody comes in with, for example, a car accident, and they took a steering wheel into the chest, it's not uncommon for them to have a pericardial effusion, and we want to make sure what the status of that is. Okay, so the direct visualization of the pericardium. In disease-free states, normal pericardium is rarely visualized. Normal pericardium is a highly reflective structure. That's the white that you typically see when you see, for example, a long axis view. You get the very, very white down here. This is actually pericardium. We're not visualizing the pericardium, but it's just a highly reflective surface. A bright pericardial echo should not be used to establish constrictive pericarditis. Again, that's the normal view. Masses and stranding can be identified with 2D. If stranding is detected, this implies a marked inflammatory or possibly hemorrhagic etiology. Figure 9-16. Scroll down here and get you 9-16. Let's see here. Let's get to 9-16. Okay, you'll notice in 9-16 where the arrows are pointing to, this is actually some stranding that they're referring to. It's also seen in uremic or infectious pericarditis. You have masses within the pericardium occasionally, and that would be seen in 9-18. This is an actual mass within the pericardium, this little guy up here at the very top. With M-mode echocardiography, an indirect assessment of pericardial anatomy can be made. Increasing the dampening of the M-mode beam to a point at which the myocardium is no longer visualized will visualize only the relatively denser pericardial echoes. A rough assessment of the pericardial thickness and echogenicity can be obtained by this means and has been one of the M-mode signs of pericardial constriction. What they're referring to is you record the M-mode in a patient with constrictive pericarditis, thickened posterior pericardial echoes to the right of this frame in the area marked by the black bracket. Dampening has been increased to suppress the fainter myocardial echoes. Note the bright pericardial echo has not been suppressed. Also note the flat motion of the posterior wall. All right, so what you've got is this is the pericardium down here that you're referring to. And that's what they're looking at, this little piece down in here underneath this arrow. Okay, so to differentiate a pericardial and a pleural effusion, as I said, you differentiate the pericardial and the pleural effusion by telling where it is in relation to the descending aorta. Okay, so let's go back up to figure 9-10. And apologize for all the scrolling, but I want you to see these actual images, or actually see these figures while I'm talking about them. All right, the difference between pericardial effusion and pleural effusion. This out here, and we'll have to get you some better pictures. This out here is pleural. This in here, right around the heart, is pericardial. This is pericardial. This out here would be pleural. When you look at a picture of the heart, let's go down to 9-14. You have a descending aorta, and the descending aorta is your spotlight. That is your landmark. This is your descending aorta. Okay? This is your pericardium, this white line with the arrow. The above it is the pericardial effusion, below it is a pleural effusion. If the effusion is below this line that attaches to the descending aorta, it is pleural. If the effusion is above the descending aorta and next to the heart wall, it is pericardial. And you'll see more images of this as we go. So fluid appearing exclusively behind the left atrium is more likely to represent pleural. Locations of the fluid-filled space with respect to the descending thoracic aorta is what we're looking for. Fluid appearing posterior to the descending aorta is more likely to be pleural. Fluid appearing anterior to the aorta is more likely to be pericardial. When both are present, frequently identify the parietal pericardium serves as an excellent anatomic landmark to define the extent of each of the two fluid collections. Again, this line that says pericardium, you definitely can identify where the pleural stops, the pericardium, and then the pericardial effusion starts. So that's it for this particular section. That's part 1. In part 2, we'll discuss cardiac tamponade. And as always, please go to Google. As always, go to Google. You'll find plenty of images that you can search for dealing with pericardial effusion. There's more than enough material on the web to give you a lot of different variety of images. Look at as many as you can. If you see some that you don't fully understand what they are or need help identifying the specifics, please give me a call. More than likely, the best thing would be to send me an email with a link to the picture. I'll take a look at it and I'll see if I can get you some feedback for it. So as always, continue your studying, and that was our discussion of pericardial effusion.